Okay, the fibula, always tricky to sight, and the clue really is at the back and the posterior fossa. This should always be posteriorly, and as you know, this will be the lateral malleolus. So if it's on this side and you hold it there, that's not quite going to fit. Whereas here on the posterior surface, that's where it sits as the lateral malleolus, and it has a sharp ridge on the internal aspect, medial aspect, for the interosseous membrane. So this is the left. It has a head with a facet that contributes to the proximal tibio-fibular joint, a neck that has a close approximation with a common peroneal nerve and can be damaged. It's important to respect it. A lateral plating surface, a medial triangular ridge for the interosseous membrane, and here the lateral malleolus with its posterior fossa at the back. So important is the head that already has the common peroneal nerve that wraps around it, and the biceps femoris also has attachment to the head, and then the superior tibio-fibular joint, where the shaft laterally has attachments to the peroneus longus and then peroneus brevis on this lateral flat aspect, and that's also the plating surface for mandibular reconstruction. Whereas the anterior has extensor digitorum longus, extensor hallucis, and then right at the bottom here, peroneus tertius as well. And then the interosseous membrane gets split to reveal usually the pedicle that runs in the peroneal artery, which actually runs in the posterior compartment. And as you raise it here, you will see the FHL as well as the soleus that has attachments deep, and the FDL and FHL as well. In terms of doing flaps on it, important to always preserve the proximal and distal 6 centimeters to protect the peroneal nerve and to protect the integrity of the ankle joint. You can then harvest pretty much the whole length of the bone, depending whether you want the perforatus located on the distal third lateral aspect and Dopplered out, and whether you do an anterior or posterior approach. You still have to split the anterior intermuscular septum, peel off the muscles, usually make your bone cuts and then rotate it out, carefully dissecting off the interosseous membrane because the pedicle lies underneath, with the tibial nerve just underneath there as well. And the tibial vessels will be deep as you start peeling off FHL if you really want to, but it's a bit of a bulky flap. But if you're worried about it, you can take a peel of it, and here you can also take soleus with it because the perforators sometimes come through with soleus. Try and cut as high as you can to give yourself as long pedicle, and usually gets a bit tight for room here, but you can usually drop the fibula out by that point, not leave it hanging. Make osteotomies on your lateral surface, it gains its blood supply from a nutrient vessel and periosteal blood supply, so you don't want to strip it completely. Make 1 or 2 osteotomies, ideally with none of your segments less than 3 centimeters in size. Great flap, can combine skin, osteocutaneous, muscle with it as well.